All right, good morning, everybody. We're going to talk today about some cysts and how to kind of approach these. We're not going to talk about every single cyst that you can encounter in the skin. There's quite a few. We're going to talk about maybe 13 or 14, something like that, just kind of get a general overview and kind of give you some ideas about how to approach cysts when you see something under the microscope. So the first thing to probably ask yourself is what is a cyst? And a cyst is something that is an epithelial lined space in the skin. It's lined by an epithelium. We name the cyst by the type of epithelium that it is lines the cyst. And by far the most common are cysts that involve the follicular structures, follicular cysts. And given that there's three parts of the hair follicle, as you all know, there's the infundibulum, there's the isthmus, and then there's the inferior portion of the follicle, which contains the tricholimal sheath, the matrix, that sort of thing. You kind of use those components of the follicle to name the various cysts. And so that's probably the most important fundamental thing to remember when you're just thinking about a follicular cyst, for example. And then there's a few other cysts from different parts of the body. You can get like a thyroglossal duct cyst. You can get, cyst like from the, like a dermoid cyst. We'll talk about that in a minute. You can get cysts involving the eccrine and apocrine glands. So those can be hydrocystoma, that sort of thing. So we'll go through and show a few of those. But this at low magnification is a nice example of a follicular cyst. I think we kind of chose this one in a way because it really does show that the infundibulum of the follicle is the area that's involved here. So you can see the basically this is the infundibulum. If you had a small hair follicle, this would be the infundibulum, and when it gets larger and forms a cyst, and the lining looks like that of the infundibulum of the follicle. It's stratified squamous epithelium, and you can see that over here. And we'll compare that when we talk about a tricholimal cyst, which is a little bit slightly different. Now, some people call those Pylar cysts, and that's basically lining that looks kind of like that of the maybe kind of close to the inferior portion of the follicle, which is kind of forming the inner root sheath, if you will. So this. You just saw this at high magnification, say, well, that just looks like normal skin, looks like just stratified squamous epithelium. And that's pretty much what you see in a good old-fashioned sort of infundibular cyst. A lot of people call these epidermoid cysts. That's okay. There's a lot of old terms that are in the literature related to that. But if you want to be kind of more precise, you can say that it really looks more like the infundibulum of the follicle. So infundibular cyst. Okay, so that's basically just good old-fashioned epidermoid cyst. Here's another part of the same lesion. Clinically, these might, sometimes they look like comedones, or this one might actually have looked like a comedo because the follicular ostium is quite large and expansile. Most of the time when we see these, we just see a little tiny follicular ostium, and the cyst is kind of beneath that. But this one's got a large dilated follicular ostium. Now, this is the so-called tricholimal cyst or Pylar cyst. These are commonly seen on the scalp. As you can see, they're very well circumscribed. They're often deep to the epidermis, or usually kind of in the mid-reticular dermis. These, you basically form a little incision over these, and they just basically pop out, and they come out like little marbles. So if you're excising these in the clinic, you usually can get these out pretty easily. So we look here, we look at the the lining of this cyst, and it looks different than stratified squamous epithelium. There's no cornified layer here. It's going directly from these clear staining cells here to this little slightly parakeratotic. It's a cornified material, but it doesn't look like the stratified squamous epithelium with the basket weave cornified layer that you see normally at the surface of your skin of the infundibulum. It's basically got this pink hyaline-like keratin, which is analogous to what is happening when you're forming the part of the internal root sheath of the hair follicle. So it's basically just a cyst of that part of the follicle, and it fills up with this pink homogeneous keratin, and gives you this pattern that we all know and very well. This basically tricholimal cyst, or basically Pylar cyst. And Pylar basically just means hair, so it's probably not the best name for this, because we're talking about the whole hair follicle. Different parts of the follicle can form a cyst. So basically, the infundibulum is it's a part of the follicle as well. It may not be where the actual hair shaft is forming, so that's probably why they originally named this Pylar way back when they did. And these lesions often will undergo calcification, and you can see that right here. This purplish crystalline material is calcium. So anytime you see this under the microscope, you know that it's calcium. Now, a lot of these don't calcify. They can, but they don't have to. So don't confuse this with the pilomatricoma, which we actually don't have an example of today. So basically, we have the infundibulum cyst, infundibular cyst. This could also be called a tricholimal cyst, or you can actually call this the isthmus catagen cyst, which is what Dr. Ackerman named this, because he said, well, if you look at the catagen stage of a hair follicle, basically the inferior portion of the follicle starts to crumble up. You get this markedly thickened, glassy basal membrane zone at the outer periphery of the follicle as it's collapsing in on itself. So he said, well, that kind of looks like the catagen stage of a follicle, and it's at the isthmus kind of area. So it's kind of like, looks like the isthmus of the follicle, but also looks kind of like the catagen stage of the follicle. So he called it an isthmus catagen cyst, which is, kind of tells you a little bit about the lining of the cyst. And then pilomatricoma is basically called infundibulomatrix cyst, because that has areas that look kind of like an infundibular cyst in some areas, but it's also got the matrical component with the shadow cells. And I think we probably didn't include this because it doesn't have the name cyst tied in with it, but it is a type of cyst also, rather than really being a tumor. So it's a cyst that involves the upper part of the follicle and the inferior part of the follicle, and you get the shadow cells there, as well as the basophilic matrical cells. So that's why it's called a infundibulomatrix cyst. Then you get this cyst, which looks like the isthmus and the catagen, but also like the tricholimal differentiation, tricholimal keratinization that's going on in the cyst. And then you get the infundibular cyst. So those are the three main cysts of the hair follicle. And we'll talk about a few others that kind of go along with that in a minute as well. Okay, so sometimes you get this tricholimal cyst, Pylar cyst, isthmus catagen cyst, where you get marked proliferation of the cystic epithelium, the cyst epithelium. So you see here, you get all of these little, they almost look like multiple little tiny tricholimal cysts that basically have kind of come together, lumped together, if you will, to form one giant lesion. And this is what we call a proliferating tricholimal cyst. Some people also call it a proliferating tricholimal tumor. WEN is another name that's been applied to these. This is a benign lesion, and that's probably the most important thing, because you do not want to overdiagnose these as squamous cell carcinomas. Just because they're large and just because they've got all this, cornification and squamous differentiation, doesn't mean that it's malignant. And if you look at higher magnification, you can see there's squamous eddies here. Squamous eddies almost always go along with benign lesions. It's got a warty appearance, got this kind of glassy appearance to the cytoplasm that's usually associated with very well differentiated squamous epithelium, low aggressive biologic behavior. So this is not a cancer, and you don't want to necessarily call it a cancer. Now, these lesions can, just like any adnexal neoplasm, if you leave them alone for many, many years, they can gradually sometimes undergo malignant degeneration. So you'd want to examine this lesion to make sure that there weren't any areas that were obviously asymmetrical and had features that looked like they were degenerating into cancer, but there was none of that here. This is basically a totally benign lesion. And just important to recognize this as not being cancer. And this is a nice example of the kind of outer part of the lower, I'd say probably, it's not really the matrical part of the epithelium, it's really kind of the outer root sheath, inner root sheath, the tricholimal sheath, if you will. These are more of the germinative cells, the outer root sheath of the follicle, kind of recapitulating the internal root sheath of the follicle, and then finally the cornification. That's kind of recapitulating the primitive hair shaft that's being formed here. So totally benign lesion, not anything to worry about. Calcification again, like we saw in the other lesion a second ago. Just remember that this is an example of a variant of a cyst that undergoes this proliferation, and it's not cancer. Rarely can turn into cancer, but usually not. Okay, a different kind of cyst. And here we're not actually in the hair follicle itself. We're actually looking at the, it's almost kind of like a milium, if you will. This is probably the level of the infundibulum and where the sebaceous gland is forming, and the sebaceous duct that leads into the cyst here. So this is probably forming at the level of the matricle probably the little stem cell region of the mantle zone, if you will. And it's a cyst that's lined by this very thin layer of epithelium. It's got like 2 or 3 cell layers here. It's got almost looks like a little cuticle. It's got this sebum-like material in it. It's got these squames. It's got these multiple hair shafts within it. And so it also has a sebaceous gland at the periphery. Now, this isn't classically what you see with a steatocystoma, which we'll look at in the next slide. This is more of what you see in a person that's got an eruptive, this is an eruptive vellus hair cyst. It's got all these vellus hairs in it. It's got the very thin lining that does not demonstrate this jagged corrugated lining that you see classically with the sebaceous duct of a sebaceous gland. So this is a different type of cyst than a steatocystoma that I'll show you in a second, because it's got all of these little vellus hair shafts within it. So this is a vellus hair cyst, and these can be seen in a solitary fashion or an eruptive fashion. And I'd say it's kind of the exception rather than the rule that you actually get a sebaceous lobule in the wall. I think all this is telling us that this is probably analogous in some ways to a steatocystoma. It's probably that same type of cystic epithelium that is being recapitulated here. It's not really the sebaceous duct, but it's probably a cyst that's really at the level of the infundibulum, maybe kind of where it's beginning to form the sebaceous duct, if you will. So, and it's got all of these vellus hair follicles, which we see like in patients, for example, that may have trichostasis spinulosa. They get 4 or 5 little vellus hair follicles inside a dilated follicular ostium. So this is probably analogous to that, but it's just formed an actual cyst that's lined by this very thin epithelium. And the epithelium is thin because of the type of cyst that this is. This is not compressed. It's not like smushed and made smaller. It's really only about a 2 to 3 cell layer thick wall. And that's kind of analogous to what we'll see when we look at the steatocystoma in a minute. So key to this diagnosis, thin wall, 2 or 3 cell layers, no corrugated lining, may or may not have a sebaceous lobule in the wall. I'd say most of the time no, and all of these vellus hair shafts in there with these squames that would be sort of analogous to sebum in a way. And these can occur in an eruptive fashion, and they can kind of look like steatocystoma multiplex. You get lots of lesions on the chest area, for example. Okay, now this is an example of a steatocystoma. Looks a little different than the last one. And probably the thing I really want to call to your attention here, even though we don't have a lot of sebaceous lobules in the wall of this, it's got the beautiful example of the corrugated, this here's got the sebaceous in the wall here. It's got the corrugated lining. Apologize that it didn't scan too well and it's kind of fuzzy, but you can see that it's got this corrugated thick cuticle, if you will. That's classic. Here's another example over here. Sebaceous lobule in the wall with the corrugated jagged lining that's got this pink hyaline, basically like a cuticle. Okay, so just imagine that you're a little miniature person and you decide you're going to walk across somebody's skin and say, hey, here's a hair follicle, and I'm going to walk down inside there. You're first going to get into the infundibulum of the follicle, then you're going to get into the mantle zone area, and you're going to see a lot of little things kind of basically connecting into that zone between the base of the follicle and at the isthmus there. You're going to see a sebaceous duct coming in there. If you're on an area there are apocrine glands, you're going to see an apocrine sweat duct go in there. You may see some germinative cells that may be prepared to form a new follicle that may be cycling in an anagen, catagen, telogen fashion there. So you can see a lot of little cool things going on right there in the mantle zone. And so if you kind of say, well, I'm going to walk into this one little area that looks like it's towards a sebaceous gland, and let's say you kind of enter that area, and then you take a deep breath and you blow, and you blow and it turns into a cyst. Well, this is what it looks like. It looks like the sebaceous duct that is just expanded and it's pressed, maybe not really doing this, but you can kind of think of that way. It's pressed the sebaceous glands that are connecting into the duct at the periphery. And so that's why you see all these sebaceous glands here in the wall of the cyst. And that's characteristic. So, and this, as opposed to the previous lesion, has got the corrugated lining. This one doesn't have corrugated. Okay, so this one's just got the thin layer. The Stylocystoma has got the corrugated lining. So remember that corrugated, it's probably got about maybe 3 or 4 round cells and lining the lesion. That's not really like stratified squamous epithelium. I'm sorry, it's so fuzzy. But sometimes it's better to look at the pattern as opposed to the cytology. So that's okay. But you can see the corrugated lining, the cuticle, sebaceous lobules in the wall, and then you don't have a lot of the vellus hair follicles or the squames in this lesion. Okay, so this is Stylocystoma. And those can be single or they can be multiple. And I think the multiplex form can even be genetically transmitted. Okay, this is a different kind of cyst. Now, some things get called cysts, okay, but they're not. For it to be a true cyst, it really needs to have an epithelial lining. So there's a lot of people that use the word cyst sort of sloppily, if you will. And this is one example of that. This is a so-called pilonidal cyst. It's not a cyst at all, really. It's basically a situation where you get, it's kind of like really implanted ingrown hairs with rupture of those ingrown hairs. It's usually seen at the base of the spine, as you know, but you can also see it in barbers, hairdressers, and they get implantation of these hair shafts. And these are not necessarily vellus hair shafts. A lot of times they're terminal hair shafts. They get implanted in their skin. They get this granulation tissue, this inflammation, and they really don't have a true cyst. So this is really where hairs get implanted either traumatically, like at a barber, or they get implanted traumatically by sitting on the area. So truck drivers, people that are airplane pilots, they're constantly pressing that area down and they end up getting hair shafts get implanted in the area, and then they get a cystic lesion clinically. Looks like a cyst clinically, but it's not really a true epithelial line cyst like the other ones we just looked at. So this is called a pilonidal cyst. Some people also call it a pilonidal sinus, which is probably a better term in some ways. But even in that situation, sinus tract usually has epithelial lining. This one, as you can see, doesn't have any of that. It's basically just these implanted terminal hair shafts here inside this skin here with this granulation tissue and inflammation. So this is what you see with the so-called pilonidal cyst or pilonidal sinus, and it's not really and truly a cyst. And as I recall, when I took my boards many years ago, they had a non-sacral pilonidal implantation cyst, quote unquote, if you will, from a barber. And, you have barbers cut your hair, they hold the, hair between their fingers, they clip, and then, if most of you men out there, you've gotten, haircuts, you always know you get hair shafts in your shirt and you got to wash that, and it gives you, irritant dermatitis on your neck and everything. Well, this is basically the same thing that's going on if you're a barber and you're cutting hair every day. Sometimes you get these hair shafts get embedded in your skin, and you get a papule there, and you biopsy it, and it looks like this. So just remember that this, while it's called a pilonidal cyst, it's really a misnomer. So it's not really a pilonidal cyst. Okay. Now this is a cyst, okay, but it's not a follicular cyst. So we've seen follicular cysts and cysts lined by the epithelium of the hair follicle. Now we have a cyst that's lined by the epithelium of an eccrine gland. So this is occurring at the level probably of the eccrine sweat duct. For some reason, it gets plugged up, it forms a cyst, and then you look at it in high magnification, you see it's lined by these, one or two layers of this cuboidal epithelium, very small, thin layer with this amorphous material in the center of it. It's kind of grayish, granular, and this is basically eccrine sweat. So this is an equine hydrocystoma. Now we see apocrine hydrocystomas also, and we don't have an example of that today, but if you see one of those, basically that will have the apocrine differentiation in the wall of the cyst. You see the elongated cells with the apocrine differentiation, the snouting there, and the material inside the cyst of an apocrine hydrocystoma is usually a little bit more eosinophilic because it has more of a proteinaceous character to it. This material is mostly a little bit of protein in it, but certainly not to the same degree than apocrine sweat gland, where you're actually taking cytoplasmic products and putting them into the secretion. Here it's basically almost like water, if you will. So this is a different type of secretion. This is an equine hydrocystoma. These clinically often look like little bluish papules, are often on the head and neck area. The eyelid's a common location for these. They may be associated with certain syndromes, like hydrotic ectodermal dysplasia can have these. And they may, if they're solitary, have kind of a bluish gray color, and they get submitted as roulette basal cell carcinoma, or sometimes even roulette, something like a blue nevus, and people think they may be melanocytic in nature. So anyway, that is an equine hydrocystoma, so lined by epithelium. Once again, it's a true cyst, but it's not a follicular cyst. Okay, so that's an equine hydrocystoma. Now this lesion, I'm kind of getting into things that are a little bit rarer. So this is a so-called dermoid cyst. And dermoid cysts, often seen in children, they're often on the head and neck area, and they sometimes will have multiple different kind of lines of differentiation in them. Usually they have, it kind of looks like the infundibulum. It's got stratified squamous epithelium with vascularly cornified layer. It's got sebaceous lobules associated with them. So this isn't a steatocystoma. It's a larger lesion, and it's lined by a different type of lining, but it's got sebaceous elements to them. Sometimes you'll see other elements in a dermoid. You'll see, usually very commonly, you'll see, and here you've actually got some of the hair shafts within them. You've got some possibly, these are macrophages that look like they've maybe engulfed some maybe proteinaceous material, so there might even be an equine or an apocrine component to these. But it's very common to get, it's not the same as a Bellows hair cyst, because a Bellows hair cyst got that very thin lining. Here you've got a larger, more stratified squamous lining with vascularly cornified material in it, not that sort of squames that we saw a minute ago. You've got these inflammatory cells, you've got these multiple large terminal hair shafts, and you've got sebaceous lobules. So really this is kind of almost like a hammer toe where you've got multiple lines of things going on here. And very common to get these large numbers of these relatively large hair shafts in these lesions. And when you see these, when you kind of cut into these things clinically, they often will have like a clump of terminal hairs within them. So it's kind of an interesting lesion. They're often seen on the near the, say, the eyebrow area in a child. And basically the way to kind of I guess the way to think about this is kind of almost like a hybrid, if you will, between a regular follicular infundibular cyst, a steatocystoma, and a vellus hair cyst, kind of all lumped together. So it's not just one of those, it's kind of got features of all three of them together. So just kind of think about that's kind of the way to diagnose a dermoid cyst. And it's a little bit esoteric. I kind of doubt that you would get this on the examination. Some other kind of esoteric cysts that we do encounter are the branchial cleft cysts. I mentioned fibroglossal duct cysts in the past. When you look at those cysts, they're usually lined by respiratory epithelium. So there you're going to look for stratified, pseudostratified columnar epithelium with cilia often on the surface. And then you'll also look for cartilage, because they also will have some of the branchial cleft remnants with them. Some of the branchial arches will be there. So you may see a little bit of cartilage. You may see some thyroid. You may even see some thymus tissue in those cysts. So those are just things to think about as well. And, you know, it's possible the board might show you one of those. It might be worth spending a little time just familiarizing yourself with it. I wouldn't expect to get a lot of questions about that, though, because it's a little bit unusual. And this next cyst we're going to show you also is rare. But again, so you say, well, okay, it's a cyst, probably. We're going to take a look at it. We're going to see what kind of lining it's got. And as we look at this one, we're going to see something that's completely different. This almost looks like it's got gastrointestinal lining. So it's got these goblet cells here, and it's got a little central vascularity to it. It almost looks like it's recapitulating either the duodenum or the jejunum, if you will. And so it's got a papular morphology to it. It's got a cystic, well, it's not cystic, it's a true cyst, but it's lined by GI epithelium with all these goblet cells in here. So this is a nice example of this cyst here with this true lining. And when you see something like this, say, wow, this is relatively rare and usual. This actually often occurs in children. It's seen in the area around the umbilicus. And it's basically, this is an omphalomesentéric duct cyst. Okay, now you don't probably need to know much about that, but I would just, if you see something like this on the board, and it looks kind of like it's GI epithelium, and notice how over here, it's contiguous to stratified squamous epithelium. So just think about where this might be occurring. So you've got, say, normal umbilicus tissue, and then you've got this red or eroded area with this this tissue that is recapitulating the gastrointestinal tract epithelium. This is kind of what you can see at the side of things like when people have colostomies and things of that nature. You can see it's kind of where the GI epithelium and the stratified squamous epithelium join together. Almost, we recently were out in the Joshua Tree National Forest area, and there's two different types of deserts that kind of collide with one another. One's got a lot of rocks and boulders with it, and one's more like a traditional arid desert with a different kind of terrain. This is sort of analogous. You've got two different types of epithelium here that have collided. So you've got stratified squamous, and you've got GI epithelium. And so you see that in a relatively few number of situations, like basically where you have, say, like a colostomy or an ostomy site. You see it in this situation where you've got this omphalomesentéric duct cyst. If you biopsy like a Barrett's esophagus, or you biopsy areas, say in the GI, where you got maybe in a colonic epithelium can basically collide with stratified squamous epithelium near the anal area, you can see these kind of collisions of these two different types of epithelium together. But if you see something like this, you've got a cystic area over here that's really lined by epithelium. Then you've got this little papule, and it occurs in a kid, maybe clinically looking kind of like a pyogenic granuloma. Think about this omphalomesentéric duct cyst. Okay, so that's relatively rare, but at least hopefully you learn something from it. Okay, next, this lesion is probably actually does originally come from a cyst, but when we see it, we almost never really see the cyst. Okay, and so when you see a biopsy like this, well, what part of the body are we on? Well, it's on an area where there's stratified squamous epithelium, but there's no cornified layer. There's no follicles here. So you say we're probably on a mucous membrane. And in this case, we happen to be on the lip. And as we go to higher magnification, you can see that there's all this mucin here with all these inflammatory cells, neutrophils, plasma cells, macrophages that have engulfed the mucin over here. So we've got mucophages. And this is a mucocele. Okay, now that's not really a cyst. A mucocele is not really a cyst, but how does a mucocele really develop? Well, it actually develops, it's a salivary gland duct cyst. So the minor salivary gland, the duct that's coming out of that salivary gland gets plugged up. Behind that, it starts filling up with mucin. And if you biopsy it at the right time, you can actually see that it's got the lining of the salivary duct with it. But because they almost always don't last very long, they're kind of like bubbles, they rupture. By the time you biopsy it, and it becomes a papule clinically, and these are usually clear. They look like bubbles clinically. They look like small little clear staining, clear appearing. That almost looks like a vesicle off of the mucous membrane in the lower lip. And you biopsy it, and it looks like this. You see all of this mucin with this inflammation, even though it kind of looks clear clinically. Histologically, it still has a lot of this inflammatory infiltrating there, but it still looks usually like a little bubble on somebody's lip. And usually when people get these, I say, wow, there's some kind of elevated bubble there on my lip. I don't like that. And they bite it. And these things usually just resolve following that. They often occur as a consequence of people that bite their lips, or there's, you know, a traumatic insult that leads to these. And the little salivary duct probably gets severed. And when it tries to regrow, it forms a cyst behind it, and then it ruptures pretty quickly. And then it ends up looking like this mucocele. So all of this material here is epithelial mucin from the salivary gland, minor salivary gland here. It's got that grayish blue mucin characteristic that we're so used to seeing with mucin. So a beautiful example of that. It's a nice example where the clinician just basically punched out the whole thing. And you look down here at the bottom, you can see the nice example of the minor salivary glands. So here's the mucin being produced by these glandular epithelial elements. And that looks very much like the same mucin that you see within the actual mucocele overlying it. So it's kind of rare to actually see the true cyst of a mucocele just because they rupture so quickly. Okay. Now the next one is also a lesion that's not a true cyst. We have the pilonidal cyst. Well, that's not really a true cyst. This also gets called a cyst, but it isn't a cyst. And you can see what part of the body you're on. Hopefully by now you would take a quick look at this and say, yeah, that's probably volar skin. And indeed it is. It's got this markedly thickened epidermis with a hypergranulose hyperkeratosis. And then centrally, once again, you've got this collection of mucin. And so if I ask you, is this a cyst? Your answer should be no. It doesn't have an epithelial lining. So even though it gets called a cyst, it's not a cyst. And it basically gets called a digital mucocyst. Usually occurs in the digit of the hand, usually on the PIP area. Patients usually have osteoarthritis. And what's really going on here, it's not a cyst. It's basically someone usually has a bone spur underlying that's causing some type of an irritation or stimulation of the perichondrial fibroblasts in the joint space to produce an excess amount of this mucinous material. And then it forms this clear staining bubble, just like the mucocele, if you will, that occurs usually in the dorsal part of the digit. And it's covered by an epithelium. It's kind of got a little roof to it. And when you biopsy it, it looks just like this. And all of these are fibroblasts and some histiocytes. And anytime there's abundant mucin, you're going to see mast cells, and maybe a couple of those here. There's a mast cell there. So this is basically what we call a focal cutaneous mucinosis or focal digital mucinosis. It's not really a cyst. You talk to the hand surgeons, they'll say, oh, there's a communication back with the joint space. There may or may not be. And if you go back and excise these, they'll say, oh, there's the lining of the joint space is communicating. And if you cut that out, these things are healed. They're probably just kind of debriding the area and cutting it out, and they may cut out the bone spur. And then you get these fibroblasts kind of quiet down, and they quit producing all the mucin. So that's probably why the surgery often works on these. You don't have to do surgery on these. This guy just did a shave biopsy on it, probably got rid of most of it. You can inject it with high potency corticosteroid. That sometimes works. Sometimes people say, well, you got to be careful because these things may communicate back with the joint space and you get steroid in the joint space, but you kind of need that to decrease the fibroblastic activity if you're going to treat these with the medical approach as opposed to a surgical approach. So anyway, that's so-called misnamed digital mucus cyst. Now here's another example of a lesion that, again, is probably not a true cyst. So I get it straight for you here. And notice here's the epidermis, the dermis, the subcutaneous fat, and way deep to that here. We're looking way down in the area beneath the subcutis. So we're down in the dermal sub-fat tissue. And here we've got this proliferation again of these fibroblasts with this thick collagen. There's a lining. Again, this is not really epithelium. It's just kind of a very thin layer of this flattened, probable analogous once again to the joint space, which is not really an epithelial line space. It's a space that's really got fibroblast and cartilage and all that's in the joint space. And this is basically what you see when you biopsy a ganglion. And these also are called ganglion cysts, but you can see it's not really a true cyst. It doesn't have an epithelial lining. So just like we wouldn't call a venous lake a cyst, that's basically a thing that's round and it's got a lining, but it's endothelial and it's got blood in the middle of it. Well, here you got a lining that's probably got this little mesenchymal layer of these cells that are recapitulating those in the joint space. And there's often mucin in the center of these. We don't see much mucin here because it's probably washed out, but this is a ganglion. And these also sometimes get called bursal cysts because they're basically probably recapitulating the bursa of the joint space and the joint area there. But they're not really true cysts per se. But this is what they look like. So just make sure you know what one of these looks like. Benign lesion, often usually seen over the joint space. Often if you traumatize these, and they used to drop, dictionaries and books on top of these things to get them to kind of rupture. Painful, but when they rupture, basically what happens there, it induces a lot of inflammation. Then you get scar tissue that replaces these, and then the fibroblasts that are producing the mucin quit producing mucin and make scar tissue, and it kind of goes away from that region. So you're not really removing the lesion, you're just basically turning this into a scar, and that's how they end up going away. Okay, the last one of these is also not a true cyst. Okay, it's called pseudocyst, so maybe that's good because at least it's basically, according to the name, it's not really a real cyst. And here we're seeing a deep, maybe shave and incision biopsy, and the main pathology here is going on in the cartilage here. And basically what we have here is degeneration of the cartilage in the center of the cartilage. Okay, and that's important because there's no inflammation here. There's no lymphocytes that are kind of invading the cartilage from outside in, like we might see in relapsing polychondritis, for example. Here we've got this acellular degeneration of the central part of the cartilage of the ear. And you can see that it's lost the chondrocytes. It's basically kind of turning this basophilic goo. And this is what we call pseudocyst of the auricle. So why do we call it pseudocyst? Well, clinically, it kind of looks like a cyst. It's a thing that looks round on the ear. And just as you know, a lot of things that look round in the skin, people call them cysts, so they think they're cysts. And then when you biopsy it, say, whoa, this isn't really a cyst at all. It kind of looks like a cyst clinically, but it's actually this cystic degeneration of the cartilage of the ear. And this is induced by trauma, usually by pretty intense trauma. If you induce long-standing low-grade trauma, like you're using a lot of your cell phone all the time, or you're a nun and you wear a wimple on your ear, or you wear hearing aids, you can get chondrodermatitis nodularis helosis, which is low-grade chronic trauma that causes an ulcer and epithelial hyperplasia and fibroplasia and whatnot. This is more like what you see with somebody that gets pretty severe blunt trauma. Wrestlers commonly get this. So you see cauliflower ears, and you biopsy one of those, that's what this looks like. It looks like this degenerated cartilage within the center of the cartilage, and then it gradually gets replaced by fibrous tissue. And once you lose cartilage, just like this, it doesn't really grow back. It's not like, it's sort of like brain tissue. Once you lose brain cell, they don't really come back, so to speak. Maybe we think now some of them might, but if you have a stroke and you lose a lot of brain tissue, well, a lot of that's never going to come back. Well, the same thing is true here. If you lose your cartilage of your ear, it doesn't grow back as normal cartilage. It grows back as fibrous tissue and scar tissue. So that's why these ears get smaller, they get deformed, and they look like little cauliflowers at the end of the day. If you were to go into this do an incision and drainage of this, as opposed to like a digital mucocyst where you get that gelatinous jelly that comes out of there, here you get an oily substance. It looks like oil. It's viscous and it's oily, and it doesn't have the same tinctorial It doesn't have the same characteristic, if you will, of mucin that you get out of digital mucocyst, or you get out of Mucocele, for example. This has got a oily type of characteristic to it. So when cartilage degenerates like this, it has more of an oily texture to it. So that's, again, pseudocyst. It's not really a true cyst. So again, for something to be a real cyst, epithelial lining. If it doesn't have an epithelial lining, we say that it is cystic, if you will. And you can get spaces in the skin that are clefts. Like, for example, if you have a basal cell carcinoma that falls out and leaves you a pincus artifact, that's not a cyst. There's no epithelial lining there. That's like basically a cystic space in the skin. And then you get this kind of lesion, which again is not a true cyst. It's basically something that's degenerated and kind of gives you a cyst-like lesion seen clinically. Okay, so that's a review of cysts. It's not all of them. It's most of them. I think if you know, I think I would add to your list of essential lesions that would maybe fall into this category that you definitely need to know. I would put in a pilomatricoma. Again, some people don't really consider that to be a classic cyst, so that's why we didn't include it today. But I like to think of them as cysts, and so you definitely need to know that. You need to know that those can occur in a syndromic fashion. They can occur in association with glioblastoma multiforme in some cases. So just make sure you know about pilomatricoma in addition to these cysts here. Some of them are more important that you'll definitely encounter. You'll definitely encounter steatocystoma. You'll definitely encounter follicular cysts, Pylar cysts, the infundibular cysts. So those you're going to get on the exam. You'll encounter equine cysts like hydrocystoma and probably African hydrocystoma. So those you're going to get. And then you're going to get some of the annexal tumors that can demonstrate those differentiations as well. But some of the rare cysts, omphalomesotelic duct, highly unlikely to see that. Branchial cleft cyst, maybe, but we start getting into median raw phase cysts and ovarian, Wolffian cysts, those things, those are more esoteric, and I don't think you really need to be too concerned about those. Okay, well, thank you very much for your attention. I hope you enjoyed this today, and we will see you next week with another session. Not sure what next week's topic is, but we'll take you through some essential elements that hopefully going to help you with your board examination. Thanks for your attention.